Hello, everyone, and welcome to today's webinar on radiopharmaceutical therapy on unresectable and metastatic pheochromocytoma and paraganglioma tumors. First of all, I want to say thank you for joining us for this patient educational webinar. My name is Sheila, and I am a patient. And today I have the honor of being here with Kim, a fellow patient, and with Dr. Mitra, who I will introduce shortly. First, let me start off by saying that this program is brought to you by the Pheo Alliance, whose mission is to empower patients with pheochromocytoma and paragangliomas, their families, and medical professionals through advocacy, education, and a global community of support while helping to advance research that accelerates treatments and cures. Special thanks to Progenics for making this webinar series possible through an educational webinar and educational grant. For today's agenda, we will start off with Dr. Mitra presenting on radiopharmaceutical treatment options for Pheo and para tumors. Then I and Kim will briefly share our experiences receiving Azedra and Ludathera treatments, and then we'll be answering all of your questions. As a disclaimer, this information presented on this webinar is for educational purposes only and should not substitute the advice of your doctor and medical team because they have in-depth knowledge of your medical history and current situation. The content of this program is not influenced by Progenics or any other supporters. So let me start off by introducing Dr. Mitra, which I have the pleasure of having here today, along with the organization Pheo and Para Alliance. Thanks to them for having Dr. Mitra here today. Dr. Mitra is a professor of diagnostic radiology at Oregon Health and Science University. He also serves as the chief of nuclear medicine and molecular imaging, and he's the director of targeted radiopharmaceutical therapy. Dr. Mitra is interested in all aspects of molecular imaging and therapy. This includes adult and pediatric general nuclear medicine, imaging and PET imaging for oncology, cardiac, and neurologic applications. He targeted radionuclide therapies are of particular interest, and he is nationally recognized in this area. His research interests are primarily focused on the translation of novel radioisotopes for imaging and therapy to the clinical setting. He's very active with the Society of Nuclear Medicine and Molecular Imaging, the North American Neuroendocrine Tumor Society, and the Healing Net Foundation. So welcome, Dr. Mitra, and thank you for sharing your expertise today.
Great. Thank you, Sheila, very much for that kind introduction. And thanks to the Pheo Para Alliance for inviting me to give this talk. And thanks to everyone who is tuning in remotely and listening in. I'm really excited to be here. And my goal in the next 20 minutes is to share the medical background to this conversation and then turn it over to Sheila and to Kim to discuss the patient aspects of it. So let me share my screen and then we'll get started. Okay, so the topic again is radiopharmaceutical therapy for Pheo and Para. So the outline is very straightforward. First, I'll focus on I-131 iobenquane or Azedra therapy. Then we'll discuss Luticium Dotatate or Ludathera therapy, and we'll end with some practical considerations regarding both. In nuclear medicine, we deal with radiopharmaceuticals. This is a very basic slide just to kind of show the background to that. There is a cancer cell which expresses a certain target, and we need a molecule that binds to that target, ideally very specifically. And then that molecule is linked to a radioisotope, and that radioisotope can either be of the form that gives off radiation so that we can image the tumor, or gives off a different type of radiation that allows us to actually treat the tumor. So this combination of the isotope, the linker, and the molecule is what we call a radiopharmaceutical. When it comes to MIBG, that molecule, the full name is meta-iodobenzoylguanidine, obviously a mouthful, which is why everyone calls it MIBG for short. And it's an analog of norepinephrine. And the current FDA-approved version of MIBG has the generic name iobenguane, but you'll also hear it referred to as HSA MIBG. And what the HSA refers to is high specific activity. So it's a form of MIBG which binds more strongly and therefore can deliver the radiation more effectively to that area. The two different isotopes that are attached or can be attached to MIBG are either iodine-123 or iodine-131. The first one is only used for imaging because of the type of radiation it gives off, and the other one can be used for imaging and for therapy. So the molecular structure of MIBG is shown on the top right, and then a couple of example scans with I-123 MIBG is shown on the bottom right for a negative scan and a positive scan. Okay, so HSA I-131 MIBG, again, generic name iobenguane, trade name Azedra, was FDA approved in July of 2018, and it's indicated for the treatments of patients who are 12 years of age and older. They have to have a MIBG scan that's positive. The tumor should be unresectable, metastatic or locally advanced, pheochromocytoma or paraganglioma, who require systemic therapy. Now, before we jump into the details of this concept of requiring systemic therapy is kind of important. Here, what I'm showing are survival curves, overall survival on the left and disease-specific on the right for patients with Pheo and para. And the main thing that I want to show is that, this is ultimately a kind of slow-moving process. Of course, every patient is very different. But in this study of a relatively large number of patients, you can see that it's a slow progression. So that's important for two reasons. One is that when designing clinical trials, it's very hard to kind of look at outcomes because of this slow progression. And the second is that it's very important not to jump to any type of treatment because, again, you don't want to use something too early in the process. So I'll discuss that a little bit more. So you can identify two different goals of MIBG therapy. On the left is symptom control, and on the right is what I just mentioned in terms of altering the actual natural history of the disease and changing the time to progression or death. Because of what I just showed, that's a very difficult goal to achieve. But the symptom control on the left is a much more manageable goal to look at. And often for Pheo and para patients, we're looking at cardiovascular events as a primary indicator. Azedra was ultimately approved based on the results of this phase 2 study, which is a phase 2 study because it has a smaller number of patients. Again, this is a relatively rare tumor type, and so it's hard to recruit too many patients. But you can see on the bottom that initially 81 patients were enrolled, but in the end, 50 patients received both cycles of the therapy, and that's what the results are really based on. These are the guidelines for eligibility for the clinical trial and also what we use clinically currently. So first, again, the MIBG scan needs to be positive, and then labs need to have enough of a reserve so that the radiation effects don't cause too much of a problem. And so minimum platelets of 80,000 and an absolute neutrophil count of 1,200. There are some additional things that we look at, and again, this is very important to kind of identify so that you don't end up using this treatment too early. So we do want to identify some sort of significant symptomatic progression and or ideally radiographic progression. Either one would potentially qualify. These were the demographics for the phase 2 study. It's a lot of information. But just to focus in on a couple of things. One is that most of the patients on the clinical trial had pheochromocytoma, and a smaller percentage had paraganglioma. And the other thing to note is that a lot of these patients had many different types of prior treatments. You can see here the number of prior treatment modalities was quite significant. So that'll become important when we look at the toxicity later on. In terms of how we actually do this therapy, this is again what was designed for the clinical trial, but also what we currently use clinically. So we are using that high specific activity formulation that I mentioned before, and we're trying to give 2 cycles with a maximum dose of 500 millicuries each time, with at least 90 days in between to allow the bone marrow to recover. The actual administration only takes 30 minutes for adult patients, and we prolong it slightly for pediatric patients, and it's all done in an inpatient setting. So the primary endpoint of the clinical trial, again, was a symptomatic endpoint in terms of reduction of antihypertensive medication for at least 6 months. Secondary endpoint was actual reduction in tumor size, among a few other things. The graph at the bottom is showing the combination of the primary and secondary endpoint. So the bars in white are the patients who did have that reduction in antihypertensive medication. And then the graph itself is showing the percent reduction in tumor size. So what you can see here is that most patients had a reduction in tumor size, and also the majority, although certainly not everyone, also met the criteria of reduction in antihypertensive medication. But you can see that these two endpoints are somewhat mixed. This is just an example of that secondary endpoint of reduction in size. The left images are showing an MIBG scan with prominent uptake in the tumor, and then on the right side, the upper images before treatment and the lower images after treatment showing a reduction in size. The first thing that needs to be done when we're starting this therapy is patient-specific dosimetry. This is something that's required for Azedra and something that we talk about for Ludathera, but not required for that one. This is the guide that comes from the company, and it's, I would say, somewhat involved, but not too involved. So it's something that can be managed by most institutions, I would say, and the company gives very clear guidelines in terms of how to actually do the dosimetry. But the bottom line you can see on the right is that it involves doing 3 whole body scans, and then we take that information to calculate a specific dose. When we start either the dosimetry or the therapy, we first have to make sure that a number of contraindicated medications are stopped if they can be, and also to block the thyroid, because the I-131, if it goes to the thyroid gland itself, can cause some damage. So both of those things are important to do at the outset. Then we give a very small dose of the I-131 MIBG, again, the high specific activity, and then we do those 3 scans that I mentioned over multiple days. It typically takes approximately 1 week to get through this process. These are just some examples of what those scans look like. The left image is the initial I-123 MIBG scan, and then the subsequent images on the right are the serial I-131 MIBG scans done for the purpose of dosimetry. You can see that background uptake, for instance, here in the liver is decreasing over time, whereas uptake within the lesions is increasing over time, which is what you would expect. We take that scan information along with the CT information to calculate organ-specific dose to the lungs, to the liver, and to the kidneys. And then based on that, as long as we can give the highest amount that can be tolerated while not causing any degree of toxicity. So we'd like to achieve, again, a total of 1,000 millicuries divided into 2 doses of 500 millicurie each, but if needed, based on this information, we'll reduce it. I mentioned that this is done as an inpatient therapy, and this is how we prep our room to make sure that there's no contamination from the radiation within the room and in the bathroom. It does require a significant support from the hospital to be able to do this and to have an appropriate lead-lined room to manage it. This is one of the reasons actually why Azedra therapy is not more universally found within the US, is because not all hospitals have the infrastructure to be able to do this. The therapy is given on the first day, and then the subsequent days are there to allow the radiation levels to come down over time. So you can see here we measure radiation multiple times a day, and once the radiation is at a level that's safe, then the patient can be discharged to go home and further isolate for a few more days. Typically, this takes on average about 4 days for the radiation levels to come down to a safe level. The dose itself is delivered from a local radiopharmacy, and then we administer it, as I mentioned, over 30 minutes. And the actual administration process is not too involved from the patient point of view, but it's definitely something that requires a fair amount of expertise from the nuclear medicine perspective. After the patient is discharged, then we're basically planning for the second cycle of the therapy, and the biggest factor there is to monitor the labs and make sure there isn't any significant toxicity that would cause the second cycle to either be delayed or not be done at all. So we monitor labs weekly or bi-weekly, and if needed, we can also reduce the dose of the second cycle based on toxicity. However, there's no need to repeat all of the dosimetry once again. The results of the phase 2 study showed that there was a fair amount of transient toxicity, but again, I'll remind you that most of those patients were heavily pre-treated in that trial, so that might not be the experience in clinical practice. But these are some of the more common ones that we've seen. The patients can experience some nausea and vomiting during the admission. Of course, since you're in the hospital, we can readily give anti-nausea medication and other things to help with that. There may be some salivary gland swelling or pain. And again, we do experience some bone marrow toxicity, but that should be transient and recover over time. Long-term side effects, if the iodine does damage the thyroid gland, despite the thyroid blockade, that is something to keep in mind for a small percentage of patients. And whenever we give radiation of any type, then we have a theoretical risk of second cancers from that. But I always say that we're trying to deal with the current cancer, not theoretical risk of second cancers. So with that, I will move to Luticium Dotatate or Ludathera therapy. Here, the molecule of interest is a somatostatin analog, which has a very rich history in medicine. It was discovered quite a long time ago and was the origin of octreotide and lanreotide therapy. And even in nuclear medicine, you can see on the bottom that there are various different formulations of this attached to different isotopes for purposes of imaging and therapy. And it's been used for many decades. In the past, we used to do octreoscan imaging, but of course nowadays we always prefer a dotatate PET imaging. You can see a dramatic difference in resolution between these two types of imaging modalities, and also it takes a lot less time and is a lot less radiation. So there's really no reason to do an octreoscan unless you live in a place where dotatate is simply not available. On the therapeutic side, it's termed peptide receptor radionuclide therapy. Again, the same idea of this molecule attached to a radionuclide. Various different radioisotopes have been used over the years, but the only one that's FDA approved currently is the Lutetium 177, which again has the brand name Ludathera. In this case, because there are more patients that participated in the clinical trial, this was a phase 3 trial. One of the main things to keep in mind relative to this talk is that this entire trial was not designed around Pheo para. It's only for patients who had gastroenteropancreatic neuroendocrine tumor. So while I'll mention the results, keep in mind that it's not really applicable to patients necessarily with pheochromocytoma or paraganglioma. But the trial was designed to test whether in those patients with GEP-NETs, the administration of Ludathera helped improve progression-free survival compared to high-dose octreotide. And as most people are probably aware, the results were very, very positive, showing a dramatic reduction in risk of progression-free survival. There was also an improvement in overall survival as well. The final results of this was recently published, showing that while it's not significant statistically, it was significant clinically in the sense that it improves overall survival by approximately 1 year. And there was also an objective response in terms of radiographic reduction as well. But you can again see that this is only a small percentage of patients. So for both these therapies, really what we're trying to do is to stop the tumors from growing or causing symptoms, not necessarily so much for reduction of size. So Ludathera was FDA approved in January of 2018, same year that Azedra was, but just a few months earlier. And it's approved for patients with somatostatin receptor positive gastroenteropancreatic neuroendocrine tumors. We typically use it as a second or third line therapy, again, for patients who are metastatic, not candidates for surgery, and who are progressing on lanreotide or octreotide. That's the kind of generic thing. But what we do for, again, both these types of therapies is to very carefully select whether this is the appropriate therapy at the right time for that specific patient. So in the context of a multidisciplinary tumor board, we'll look at all these different types of factors, such as the pathology, imaging characteristics, distribution of the disease, clinical factors such as the bone marrow reserve, kidney function, liver function, and other medical comorbidities as well. Oops, sorry. So big difference between this therapy versus Azedra is that this one is done as an outpatient treatment. So this is our outpatient clinic in nuclear medicine. We do line this area again a little bit for contamination purposes, but much less than what you saw for the inpatient room for Azedra. And basically it takes approximately most of the day. Patients arrive around 8 a.m. and then go home around 3 p.m. or so, and they come for a total of 4 cycles. So in terms of the actual administration, this is, I think, much easier for patients to go through than having to be admitted to the hospital for 4 days. The actual administration takes so long because of the need to give amino acids for kidney protection. So you can see that that's here in the center, takes about 4 hours. And because that can cause some nausea, we have to give some anti-nausea medication before that. And then the actual Ludathera, just like the Azedra, only takes about half an hour to administer. After this is done, we also do a quick scan to confirm the distribution of the therapy, and then the patient can go home. Overall, the therapy, again, is given in 4 cycles, once every 2 months, approximately, again, accounting for any toxicity that might happen. But ideally, we'd like to give a total of 200 millicuries every 2 months for a total of 800 millicuries in total. I will mention that every aspect of what I just mentioned in terms of how we currently do PRRT using 200 millicuries, 4 cycles as a second-line treatment, all those things are currently being evaluated in clinical trials to see how that can be further improved. So there are trials looking at different isotopes, different molecules, different doses, different administration methods, different number of cycles. A big area is combining it with other types of therapies, and even the indication shown at the bottom of well-differentiated grade 1 or 2 GEP-NETs is also being looked at, whether this can be used in other areas. And that's where this comes into play for pheochromocytoma and paraganglioma. So far, there's only modest clinical experiences. There are some studies that are showing some successes, but other studies not showing great success. And currently, there's a large trial being done by the NIH specifically for patients who have Pheo or para and looking at PRRT, and that's really the ideal way to do it so that the study is more well controlled. So lastly, I'll just cover some practical considerations of how this is done. Since our institution is one that has both types of therapies available, what we primarily do is base the choice of the therapy on imaging. So here's an example of a patient imaged with both MIBG and dotatate, and you can see that there's a lot of expression of dotatate, but essentially the MIBG scan is negative. And so this patient obviously would benefit more from Ludathera than from Azedra. Conversely, there are other patients who show essentially equal uptake. Keep in mind that the dotatate is PET imaging and MIBG is gamma imaging, so there is going to be a difference in resolution. So accounting for that, this second patient would probably benefit from either one. And so in that case, we go with the FDA approved label and we'll use Azedra therapy instead of dotatate. But for institutions that don't have access to both, then you're a little bit more limited in how you can choose between these two. This shows a relatively comprehensive list of those places that are providing Azedra therapy. You can see that there's not a huge number, but they are scattered throughout the US. And for the latest information on the current treatment sites, you should go to azedra.com, and there's a treatment site locator that you can use. Ludathera, on the other hand, is found in, I think at this point, over 200 centers in the US. So that's much more readily available. Because it is an outpatient therapy, it's much more easy to do. So in the last minute, the key takeaways in conclusion: HSA, high specific activity, MIBG approved for Pheo and para in patients 12 years and older based on a phase 2 trial. Luticium Dotatate is approved for somatostatin receptor positive GEP-NETs based on a phase 3 trial. And it needs to therefore be used off-label for patients with pheochromocytoma and paraganglioma. MIBG therapy requires 1 week of dosimetry followed by 1 week of hospitalization, and then you do it for 2 cycles that way. Dotatate therapy is done as an outpatient visit for up to 4 cycles. And in practice, local institutions are probably using a combination of what's available to them, as well as imaging, insurance considerations, and of course, agreement from the multidisciplinary tumor board. So thank you very much for your attention.
All right.
Thank you so much, Dr. Mitra. That was very useful and helpful. Definitely a lot of very good information for Pheo and para patients that are looking into these types of treatment. So I'm going to go ahead, and now Kim and I are going to share a little bit of our experience. Kim had Azedra, and I had Ludathera. So I'm going to go ahead and share a little bit of my experience with Ludathera treatment. 2 years ago, I was diagnosed with paraganglioma at the base of my skull. The tumor was large, and it was affecting several cranial nerves, but it had metastasized to my neck, and it was encasing my carotid artery, and it was causing me to cough a lot, have shortness of breath. I lost my hearing in my right ear. I started having double vision. So it was really affecting me. And after my diagnosis, I prepared for surgery for 2 months. On April of 2019, I had an 18-hour-long surgery to remove most of the tumor. The surgery was done here where I live at the University of Miami, Sylvester Comprehensive Cancer Center. And the surgery was successful because I didn't have any major complications. But unfortunately, the surgeons were not able to remove all the tumor. There was parts of the tumor that were in areas that were very risky to operate on. So after my surgery, I spent 2 months recovering. After surgery, I experienced facial paralysis on the right side of my face. I also, experienced my vocal cord was paralyzed. I, had trouble swallowing and eating. So I spent 2 months after surgery recovering, receiving intensive physical, occupational, and speech therapy just to regain my strength and to learn how to eat and talk. And after that, I had radiation therapy and chemotherapy. I completed 33 rounds of radiation and 1 week of chemotherapy. After completing these treatments, they did a scan and it showed that the tumor was stable, which was good. Um, but I started thinking, what's next for me? I'm At the time I was 25 years old, and I thought, okay, I've gone through treatment, I've gone through radiation, I've gone through chemo. Could there be anything else out there for me? And just a few weeks later, I get a call from my oncologist, and he tells me about these two possible treatments that Dr. Mitra just mentioned, Azedra and Lutathera. So, with nothing to lose, I went ahead and met with Dr. Hussein, which was the doctor that administered my Ludathera treatment at the University of Miami. And Dr. Hussein explained to me that, you know, basically what Dr. Mitra was just explaining, there was these two types of treatment, Azedra and Lutathera. And in order for him to see which one I qualified for, I had to get a MIBG scan to determine if I qualify for the Azedra. And then I got a Dotatate PET scan to see if I qualify for the Ludathera treatment. Well, it turned out that in the MIBG scan, it came back negative. So, the tumor didn't show up in the MIBG scan, but then in the Dotatate PET scan, it didn't light up. So, um, as Dr. Mitra mentioned, the Lutathera treatment is not FDA approved for, my type of tumor, which is a skull-based neuroendocrine paraganglioma. So my doctor notified me of this, and he told me that he would try to speak to the insurance and try to get me approved. But if not, he did say that there was other centers that are like the NIH that were offering trials for the Ludathera. So I waited, and thankfully, my doctor was able to get the Ludathera treatment approved by the insurance. And thankfully, I didn't have to pay anything out of pocket, which was a huge blessing and privilege. Um, so I went ahead and did the Ludathera treatment. I started my first Ludathera December of 2019, and I did 4 infusions of Lutathera 2 months apart. And my last Lutathera treatment I was completed in June of 2020. During the Lutathera treatment, I would arrive at the center at 8 in the morning. They placed me in a room by myself. I had a nurse there with me monitoring me the entire time, and they would prep me by placing 2 IVs. In one arm, they would place 1 IV, which is where they would um, place the anti-nausea medicine and the amino acid. And then in the other arm, they would place the Lutathera treatment. Like Dr. Mitra mentioned, the actual Lutathera treatment was only 30 minutes, but the whole process, I was there at 8 in the morning, and then I was dismissed after they monitored me for 2 hours after receiving the Lutathera. I was dismissed around 3:30, 4 p.m., and I was able to go home. The only precautions that I had with the Lutathera was that I had to stay 6 feet away from people for 2 weeks. I couldn't be near pregnant women or small children. And if I were to use the bathroom, I would be the only one that should be using the bathroom. Or I would have to make sure I would flush twice if somebody else were to use the bathroom. But aside from that, one of the only symptoms that I got from Lutathera, I was a little nauseous the first like 10 minutes of the treatment. and then I also had a mild headache. But aside from that, I didn't lose my hair. Like, Lutathera was completely different than chemo. With chemo, I lost my hair. I felt very tired, very fatigued. And with the Ludathera treatment, I didn't lose hair. I was able to, after 2 weeks of receiving the treatment, I was able to, be active, go out, be with friends and family. So, it's been a long journey of healing, and I know sometimes being diagnosed with these types of tumors can be overwhelming, and sometimes it can be stressful, to navigate the whole system. But I'm just grateful that I got the chance to have this treatment, and even though I'm still recovering and healing, I've improved so much from the past year or two, and I'm happy to see all the improvements since finishing my loss with the Thera treatment. And so I hope that by sharing my story, if there's any other patients currently listening to this, and you have doubts, I hope that as sharing my story, I have answered maybe some of those doubts and fears that you may have, and just spread a little bit of hope that I'm still here a year later and I'm feeling better than what I used to. So, I'm
Are you
gonna
ready for
go
my story?
ahead. Yes, I'm gonna go ahead and give it over to Kim. He's gonna go ahead and share his story and his journey with receiving Azedra.
All right. I'm sorry for all that you went through. I think my process was pretty simple compared to what you had to go through. I started off with. I want to thank Dr. Meeter too, because he was my physician, attending physician for my treatment. But I'll get into that later. But I'll try to be brief on the diagnosis. But it was kind of a pain, drawn out thing. I had to start off with all of a sudden crazy high blood pressure, and at any rate, a bunch of scans and stuff later, they figured out I had a tumor, and then a bunch of other diagnostics, they figured out it was a pheochromocytoma. And I had that removed. My urologist, Katie Bryan, removed it on the 8th of January, 2020. And of course, and that wasn't a long drawn out surgery like hers was. It was pretty simple. It might have been a couple hours or something. I don't remember. Of course, I'm out, but I don't think it was that big of a deal. And it was orthoscopic. And it was, I think it was 60 centimeters, the size of a cue ball or a pool ball, billiard ball. But, and I had, for symptoms, headaches, and I still do wake up in the middle of the night with adrenaline rushes and stuff. But other than the blood pressure stuff, it wasn't anything as uncomfortable as what she went through. But at any rate, after the pheochromocytoma was taken out, the guy who actually determined that's what it was, with all the testing he did with urine and blood work, my endocrinologist, Dr. Hungerford, he followed up with every 3 months just to follow up after that, to make sure that those hormone levels, epinephrine and medinephrine and norepinephrine and norepinephrine, were going back down where they're supposed to be. And they weren't going back down that much. And then the next time they were up a little bit, next time up some more. And then they started doing all these scans on me, the MIBG, and whatever the PET scan was. There were about 4 of those different scans that they did on me. Then it was right before Christmas, and I apologize because the Azedra really dries you out. I got dry eyes, dry nose, and I have to moisten my mouth a lot. But and it's been, my last treatment was just over 2 months ago. But at any rate, he gave me a phone call probably about 5 days before Christmas to tell me that the pheochromocytoma had metastasized to my skeleton. and made an appointment. My wife and I went in, and we thought we were going in to find out how long I got. I'm done. Well, I had 7 locations where these lesions were, and it sounded like there was about 12 of them. I thought, I didn't know how to operate on those things. I'm out of here. So we thought we were going to find out how long I got, and then Dr. Hungerford started explaining to us how dangerous this was and how scary it was, and then he started telling us about this fairly recent radiation treatment that nuclear stuff with an infusion, that there's treatment that will prolong my life. And we were both like, I mean, seriously, we got outside and cried. Shit, looks like I'm going to live for a while. At any rate, I don't recall much after that. It was kind of a moment of celebration, but I did some more correspondence with him. I can't remember how, but it was a few months later. They set the appointment at OHSU in Portland, and I had to show up 2 weeks before my first infusion for the dosimetry that Dr. Mitra talked about. And I showed up on a Monday, and I don't remember what time of day, but they gave me the first infusion. It was kind of a simple thing. And then I think I waited about an hour, and then they did the scan, and I went home. And then over the next 3 days, I think they did 2 more scans or something like that. But I had to stay in Portland for most of the week. But then we came back 2 weeks later and checked into the room. That was all outpatient stuff. All the other stuff was, went to the room every night. But at any rate, so they checked me in. I go to this room, that the one they showed you in the picture. I'm sure that's the same room I was in. Looks like a normal room, but the whole room is lead lined, they tell me. And they had everything covered, and plastic on the floor in the bathroom. I couldn't use the shower. I had wipes and stuff is all I could do. And the door looked like a normal door, room door. They're oversized for beds to go through. But pulling it open was like opening up a bank vault door. It was just, at any rate. Then after I was in there, they wheeled in, after I was in there for a while, they wheeled in this big lead wall on the big casters. And they would peek over it and say, do you need anything? And if not, they wouldn't even come in. And sometimes when they brought me water, they would just set it around the corner and they wouldn't have to put all this stuff. Every time nurses come in to check vitals or blood pressure or something, they would have to put stuff on their head, gowns over them, gloves, footy things, and then all that stuff had to go in the trash when they left. So it was a pain in the butt for somebody to actually come in. At any rate, back to my treatment. When they first started the treatment, Dr. Mitra and Adam, who's an amazing guy, he's the head tech for the nuclear department. He's amazing. But at any rate, they came in around 4, I think it was. And at any rate, about 5 minutes in, or maybe less than that, but it just started aching. The infusion just started aching. And after about another minute of that, I'm like, I can't take it. So I had him stop it for a minute. And then he ran some saline through it or something, kind of switched it from the Azedra to the saline or whatever. And then I started pumping, and I had him do it again after a couple of minutes. I thought, this is going to take forever if we don't get this going. But pumping my hand and my wrist and stuff helped a bunch, so I didn't have to have him stop it again, and got it all done. But at any rate, it wasn't so bad, the infusion. And then after the infusion, Adam had this little Geiger counter thing. Kind of looked like an iron, only square. And he held it right at my chest and took a reading, and then held it 3 feet away and took a reading. And it was kind of a cool thing. He explained a little bit about it. And then, at any rate, so over the next 4 days, like I just said, I got to drink a lot. Mine just dry all the time. I drink a lot and often, especially when I'm talking. It dries me out. But I pretty much had him keep at least 2 cups of ice water on my tray the whole time. I was told it was important to drink lots of fluids anyway to help flush out the radiation. And I know it's probably a pain to the staff, but they were pretty good about bringing me either just ice or a couple more water or whatever. And like I say, sometimes they just put it around the corner and they wouldn't have to put all that garb on. And then about every day, Adam, the tech, would return at about 10 o'clock in the morning to take a reading. Then he'd come back about 4 and do the same thing again. And then he explained to me that once my radiation level got down below 7 at 3 feet, then I'm safe to be out around other people. Distance, but safe to leave the room. I couldn't leave that room. So that didn't happen until Thursday, and it was pretty late. I mean, it was like probably 6 or something like that. But it was too late for me to get out. Plus, they had to have a scan the morning of my discharge, so I had to stay that night. By that time, I wasn't sleeping. You know, when they first did it, I was sleeping. All I did was drink, sleep, and then wake up every 20 minutes to go pee because there was a lot of fluids. And but anyway, the next morning I called my wife and she came and got me, and she went with me to go get my scan before I left. And my recovery, besides the dryness, I still have the headaches and stuff, but I don't think that's the treatment. I think that's the tumor. But just tired and lazy, you know, more naps than normal, and the dryness and stuff. And the sleeping and tiredness kind of went away after about a month. Still a little bit there sometimes, but sometimes it's just I have to take a nap because I wake up with those adrenaline rushes still. But at any rate, I also have to be careful because I'm going for blood work. Well, they've got it down once every other week now because my platelet count is low and my white blood count is low. So until that gets back to normal, I have to go out. I think there'll be some scans once my platelets get back to where they are. But at any rate, my second treatment, it was I thought it was going to be 3 months later, and it was a little bit longer, but I think it's because it took a while for my platelets and white blood cell count to come back up. But at any rate, I had a better idea what to expect, so I planned ahead a little bit, and I knew about the dry mouth, and I had more water there. I tried to drink more. They recommended I have lemon drops, and I waited too late to look for them. I never did find them, but I got Jolly Ranchers, which were pretty good, but if you can find the lemon drops, get those. Anyway, and I took some snacks, which didn't work out. Salty snacks with a dry mouth. I couldn't taste them. Anyway, during the second one, the pandemic was in full swing, so it wasn't just masks and distance. Paula couldn't even come in there. My wife couldn't even come into the hospital. She had to drop me off and stay outside and pick me up. She had to wait outside. Kind of a pain, but this time I knew to start flexing right with the other hand, but I start flexing my hand right away. And I was starting to say that they did 2 IVs. I mean 2, but it wasn't for the same reason. I just had one that was just saline or whatever the hydration stuff is. I went through one of those bags about every 3 or 4 hours, I think it was. And the other one was for the infusion. But on the second one, I started flexing right away, and I don't remember I ever had any pain, but it went a lot smoother. I drank more water, and with every time I ordered a meal, I would order 2 cranberry juices, trying to flush this stuff out. And I tried to move around a little bit more, tried to walk over, look out the window, and try to walk. I couldn't leave the room. Wasn't much room to do much. It's not like they can bring a walker in. I'd probably ruin this thing with my radiation. But at any rate, I know that by that Thursday night, I wanted out last time, so I was trying to work to get out. By the time when you're not sleeping and then waking up every 20 minutes to pee, when you're doing so much better that you're awake a lot, you kind of want to get in a bed that's got a mattress thicker than that. I mean, it's cool that it moves around and stuff, but I wanted out. And this time, at any rate, I think I hit an 8.5 on Wednesday, and I knew I was going to get out on Thursday morning, which was a day earlier, when Adam came in and tested me. So yeah, I was discharged the following morning. Way easier because of that fact. I didn't get so tired of the room that time. So I recommend lots of fluids, cranberry juice, a little bit of exercise, what you can do. You're stuck in a room, but anyway. With both treatments, I was discharged, mid-morning kind of stuff. And I think it was both times we spent the night in Portland, and just to be close to OHSU before we took our 3-hour drive or 300-mile drive back to Medford. We live in Southern Oregon, and Portland's North Oregon, so it's 300 miles away, which is not that big a deal. But I want to say the whole experience was amazing. The staff at OHSU was excellent. The nuclear department, Adam and Amy, but especially Adam, the main tech, that guy. Of course, I came home and bragging about Dr. Midra and Adam to Paula, which she met him because he explained everything. He's a great guy. explain stuff to questions and answers before any of this stuff started in our room, in my room. But the way all those guys acted, and that mainly the main guys, they made me feel, I'm going in there for this scary thing, and getting radiated. I'm going to be isolated from everybody, treated like I'm a 1940s leper. But these guys treated me like I was a rock star. And then I had Paula, I was telling her all about how awesome they were, and she looks it up, and these guys are rock stars. These guys are somebody. Anyway, pretty amazing, and they're just like my best friends. They're in my band. But anyway, if anybody's looking for a place to go, I recommend going to Portland. And I didn't see all that crap you see on TV. It's a beautiful town. Anyway, that's probably about. Oh, if anybody's worrying, yeah, I am in a band. It's just a hobby thing. A couple of retired cops, a couple other retired guys, a mechanic, and a guy that worked for the newspaper. But and that's a cat tree, whatever. There. But this love seat is on. I put wheels under it, so I roll it out of the room. We pull the mics out, and we practice on Tuesdays. Rock and roll and country. Just old guys, something to do on Tuesday afternoon. If that answers the question about all the crap behind me. Okay, Sheila already told her story, so we got Sheila
Kim,
questions
thank
now.
you. Yeah, Kim, thank you so much for sharing your story. I mean, very inspirational. Um, even though we've received different treatments, it's very similar with the being in a separate room while you're getting treatment. I also experienced, just like you, I didn't mention it, but I experienced a lot of dry mouth and, constantly having to drink water before treatment and after the treatment. And so till this day, constantly having to like carry water with me everywhere I go. So I agree with you. And I agree that, these doctors and the medical staff, they are rock stars. For it's definitely something that I didn't know what I was going into, but just knowing, getting the whole procedure explained to me, I felt so much more comfortable. Even when I was there in treatment, there was a nurse always available. So yeah, thank you, Kim. Truly appreciate your story. So now we're going to move on to our questions Q&A. So the first question that I have for Dr. Mitra is, are either treatments, Azedra or Ludathera, an option for bladder paraganglioma?
Okay, thank you for that. Before I answer the question, I also want to say from our side, that it's wonderful. I really enjoy having these experiences and hearing these your stories from the patient perspective. We get so focused on all the data and the images and all of that, but it's it's really, you guys are the rock stars, honestly, because you go through so much and you make it look easy. So yeah, it's wonderful. Thank you so much for sharing those stories. As far as the question goes, yes, it doesn't really matter ultimately the origin of the pheochromocytoma or paraganglioma. What we look for is the uptake that we see on the scans and the overall distribution of the disease based on other imaging as well, such as CT or MRI. And as I mentioned, for both these treatments, we're typically doing them in the metastatic setting. So it's at that point, doesn't really, again, matter where the origin was. So.
Okay, understood. All right, the next question is, can you talk about PRRT and radiosensitizing chemo used together in patients? Are there good results from doing that?
Yes. So the use of combination therapies, I briefly alluded to in one of my slides, and especially with respect to PRRT, there are several ongoing studies looking at different agents that might, when used together, actually amplify the benefit of each one used alone. And the most common ones that are being looked at right now, one of them is capecitabine, which is commonly used together with temozolomide for neuroendocrine tumor, but it is thought to be a radiosensitizer. So there are several ongoing studies to look to see whether the combination of capecitabine plus PRRT can help amplify the signal. Another example is PARP inhibitors. PARP inhibitors cause DNA damage, and that's the same way that our radiation also is having an effect by causing DNA damage. So you can understand that the concept behind that study is to see if two different approaches of causing DNA damage together might amplify the signal. So I would say it's unfortunately a little too early to comment on whether or not those strategies are particularly effective. And the other thing to keep in mind also is in terms of toxicity, right? Each one of our therapies, whatever we do in medicine, we have to balance the benefits versus the risks. So that's also something that needs to be looked at in those trials is it not only effective, but is the risks also tolerable?
We have, can a pheochromocytoma metastasize, be secreting, and have uptake of MIBG, then later on after growing not secrete?
So I think I can answer this question somewhat generically to say that all types of cancers, and certainly pheochromocytoma are examples of them, all neuroendocrine tumors can evolve and change over time. And that's an important kind of consideration to keep in mind when considering different management approaches, because what started out in one area one way might subsequently change either in the same location over time, or once it metastasizes to a different location can change. That's actually one of the benefits of doing the imaging that we do prior to our therapies, is we're able to essentially look at the whole body and kind of characterize all of the lesions and make sure that they're expressing the proper receptors that we're subsequently going to do the treatment with. So yes, it is true that things can change over time, and it's important to kind of keep those changes in mind. Sometimes also in neuroendocrine, it's and other types of cancers, it's not uncommon to re-biopsy, for instance, to make sure that we're kind of dealing with the same pathology that was initially seen on the initial biopsy.
Okay. All right. The other question is, how often can you have Ludathera? I had it a few years ago, and can it be repeated?
Yes, so that's a big question in the field right now. It's called either repeat PRRT or salvage PRRT, depending on the terminology that's used. But the basic concept makes a lot of sense, is that if you've gone through the first 4 cycles of PRRT and had a good benefit, and by that, most people consider a good benefit to be at least 12 months to 18 months, even ideally 24 months before the progression starts happening again. So if the benefit is good initially and the toxicity was very manageable, then it certainly makes sense to potentially just repeat PRRT all over again. And there have been several studies that have looked at that. It's not a huge number of patients yet. It's mostly phase 1 and phase 2 studies that have looked at that. And the results are promising in that case. Here in the United States, there isn't clear approval for that by any means. And the patients who were initially treated back in 2018 are just getting to that point of potentially needing it. So I think we're going to find out soon enough whether insurance companies will once again approve PRRT for a second round or not. If not, there are, again, clinical trials that are evaluating this as an option. But I think this is going to be a big question that needs to be looked at.
Okay. Would that be the same for Azedra?
Probably the same for Azedra, yes.
Okay.
Exactly, yeah. Again, we don't have any strong data one way or the other to say that we can or can't do that, but it certainly would make sense in that same same vein, that if there's been a good benefit and low toxicity for the first time around, why not treat it? And the other related concept to that is that for patients who have uptake on both an MIBG scan and a dotatate scan, one strategy around this insurance hurdle would be to do one, and then once the progression happens, to switch to the other type of therapy, because that's not repeating it, it's doing a different therapy.
Oh, it's really interesting. I didn't know you can do that. You can maybe, switch if you had Ludathera, and you qualify for Azedra, have Azedra later on.
Exactly. Yeah. Again, based on imaging, and that's, again, the nice thing is that imaging is so straightforward to do for the most part, that you can just repeat the scans, make sure that you still have the appropriate expression of the receptors, and then go forward based on that.
Okay. I have another question. How often can you have Lutathera? Oh, no, I'm sorry, I said that already. How often is Lutathera used in the U.S.? Is it used more often for Pheo in Europe?
That's a little bit hard question to answer. I don't know that there's any numbers. I think based on what I showed in terms of treatment sites, there's many, many, many more treatment sites for Ludathera than there are for Azedra, because of the infrastructure that's required to be able to provide Azedra. Just alone in that regard, I think the use of Ludathera is much higher than for Azedra. But again, I would really advocate that patients try to get the appropriate type of treatment that they need, even if that potentially means going to a different site than the one that you traditionally go to. For instance, Sheila, your example was good. Your doctors did both types of scans and then chose Ludathera based on the uptake that it showed. That's the right approach to do it. So I would just make sure that patients kind of understand that, and don't readily just accept the first type of treatment that's offered, because Azedra is not offered everywhere.
Okay, got it. Another question is, what medications are contraindicated with Azedra?
There are many, many, many contraindicated medications in many different categories. That's kind of hard to keep track of. Honestly, there are several good publications that list all of those out. The way we manage it at OHSU is that we've built a program with our clinical pharmacists who have a very thorough list. And since they're the experts on different medications, whenever a patient is starting the dosimetry, at that point, we refer that patient just on our back end, not the patient directly, to pharmacy, who will review everything and make sure that the contraindicated medications are called out. Then we work together with the referring physician, the oncologist, or the surgeon to make sure that those medications are stopped if they can be. I will say that some medications are difficult to stop because they're important for control of blood pressure, for instance. And so you have to kind of manage that whole aspect very carefully. It's not an easy thing to do, but if you work together kind of in a multidisciplinary approach with the referring physician, the pharmacist, and nuclear medicine, then it's generally pretty manageable.
Okay, understood. We have, can you fly right after receiving these treatments?
Yeah, so I didn't cover about radiation safety precautions just for the sake of time. Sheila, you mentioned that you had to be away from other people for a while. I can make the general comment that after you leave the hospital, whether it's with Ludathera or after you've been discharged after Azedra, as you mentioned, you do need to stay isolated for a few more days after that. So as far as flying goes, that makes it a little bit tricky because you're going to be around a lot of people in the airport and on the plane. But generally speaking, I would recommend that at least a day or two should pass after after you leave the hospital after either of these treatments, and then you can fly after that.
Yeah, just to add to what you said. Oh.
Yes, please. Go ahead.
Yes, so after my treatment, after every treatment that I had, I was given a sheet of paper, and it with the instructions and the precautions to take, and it was like make sure to stay 6 feet away from people for 2 weeks, and then they also gave me a paper so that I can show if I were to travel or fly, just in case the radiation would show up. If I can show it to TSA, if I was going to fly. So
that's exactly what I was going to say, is that you should have some paperwork from the hospital that documents those radiation safety precautions and indicates that you did receive. Generically, we don't have any details in that, but just to say that you did receive it in case, because there are radiation detectors throughout travel areas.
Yeah. Okay.
Told me that if
The
I
other
was gonna
question
try to
is,
fly,
I think Kim was
I'm
going to say
sorry,
that I
Tim?
would, I'm sorry, that Amy, the other nuclear tech, told me that if I was to try to fly when I'm discharged, that I would set up all the machines and I'd probably wind up in prison. So you recommended I didn't do that for a couple of days. Sorry to interrupt.
That's true. Yeah.
Well, you'd be isolated
So
at least once you're in jail.
Not in a good way.
All right. One of the other questions is, what are the long-term side effects of Lutathera and Azedra?
Yeah, so we have more data on that for Ludathera than for Azedra because it's been used for a longer period of time, and there's large clinical trials that kind of show that. Of course, the major one is the NETTER-1 phase 3 trial that I mentioned for PRRT, and then the phase 2 trial for Azedra. For both of these, overall, as again Sheila kind of alluded to, that these are quite well tolerated, and even the toxicity that happens tends to be transient. The biggest things we are concerned about always is the bone marrow. Most patients will have a transient decrease in their counts, mostly the platelets, but also can be the white blood cells, and then that should recover after 4 to 6 weeks. In some cases, that can be more prolonged, and so that could be one thing that we are concerned about. And as mentioned, we can always delay the next cycle of the treatment or reduce the dose of the next cycle of the treatment, or if needed entirely, then we would have to stop the treatment so as to not cause any more damage to the marrow. And then the other comment I would make is that there's thought to be a cumulative effect from multiple types of therapy that you get done. So Sheila, you had chemotherapy done, followed by this type of treatment, and so that's an example where you're getting kind of a cumulative toxicity potentially from both those things. So that is a little bit unknown. It's thought to be very rare to get very serious side effects, such as myelodysplastic syndrome and other types of significant marrow issues. But those are kind of some general points that generally it's transient and recovers. Rarely it can become more prolonged, and you would need to be concerned about multiple types of therapies sort of adding up.
Yes, I just to add to what you said, since finishing my treatment, the tumor shrunk, slightly shrunk, but one of the things that was affected was my thyroid. So now I have hypothyroidism, so I have to take thyroid medicine. So when it comes to all the long-term side effects and possibilities, one of the ones that I've experienced is having to take medicine to help my thyroid, which is not that bad. I take it every morning. So
Yeah, that's actually interesting because it's more common for Azedra, as I mentioned, because the iodine 131 can go to the thyroid and cause damage. It's not typically seen with Ludathera.
yeah. All right. So moving on to the next question: what radiotherapy type would be best for unresectable bilateral glomus vagal and bilateral carotid body paraganglioma to minimize nerve damage?
So those types of tumors are very rare and located in the skull base, probably not too dissimilar from how yours started out, Sheila. And the difficulty becomes that because of the location, it's difficult to do surgery, as you mentioned. And so, what other treatments can you do? The main ones that come to mind are either Azedra or Ludathera, and then also external beam radiation can be used. There's a sort of theoretical risk with systemic radiation, such as Ludathera or Azedra, that they can cause some inflammation of the lesions, especially in tight areas like that. And so some people believe that external beam radiation is beneficial in that regard because it tends to not cause that effect. But ultimately, I think the answer to that question is it would require consultation with a radiation oncologist as well as a nuclear medicine physician, and then again discussion in a multidisciplinary tumor board to decide, what's the best strategy for that particular patient and their anatomy.
Okay. The next question is, after Azedra treatment, when should another scan be done to see tumor progression?
Right. So follow-up after these treatments is another area that is still a little bit unclear. Most centers will do some sort of imaging after the completion of the treatment is done. And by that, what I really mean is either a CT or an MR scan to anatomically look at the disease. If it has decreased in size, that's the best indicator that there has been a response to the treatment. Or conversely, if there hasn't been a decrease or a growth, then that's also very definitive. The use of functional imaging is a little bit controversial at this point, just because we don't fully know what the differences really mean, which is a little bit surprising because you would think that if the imaging is MIBG or dotatate is used to confirm eligibility for the treatment, that you would then use the same type of imaging to look at the response from that treatment. But we still need more data on that. And sometimes you can actually see slight increases or decreases, which don't necessarily translate to outcomes. But that's a very long-winded way to say that most centers, again, are doing probably a combination of molecular imaging and anatomic imaging a few months after the completion of the treatment. But oftentimes, again, because these tend to be very slow growing, that you would need to subsequently repeat those scans maybe 6 months later or even 12 months later to really see whether things are changing or they're stable.
I agree with you, Dr. Mitra. I had a scan done 2 months after finishing my treatment, and then I believe 6 months later, and then I just had a scan done last month, September. So that's a little bit over a year after finishing my last treatment. And every single time it showed improvements, and it showed like a slight shrinkage, from the previous scans. So, yeah, just to add to your
That's wonderful.
Your response.
That's great.
Yeah.
Yeah.
All right, so we're getting close to the end of the webinar. We have 2 more questions. This question is, are there any pain management options with metastatic pheochromocytoma when there's a lot of pain after the first Azedra treatment?
So certainly, there's many different types of pain management options. It's not an expertise area of mine, of course, but that is certainly something that can be managed by the primary oncologist if they feel comfortable with that, or together in conjunction with a pain management person. But there's no contraindications to doing any of that with respect to these treatments.
Okay, and then let me see. Just bear with me. Trying to get the last question.
Sure, no problem.
All right, so last question is there a way to protect the salivary gland? The weather for thyroid is protected with iron percenter, and the kidney is protected with amino acids. Sorry. Is there a way to protect the salivary gland?
Yeah, I think I get the
Percenter and the kidney protector, yeah.
Yeah, I think I got the question right. So we use potassium iodide to protect the thyroid gland from I-131. We use the amino acids to protect the kidneys from the radiation from the Ludathera. So it's a fair question to say, what about the salivary glands, which can also be damaged by some of these things? Unfortunately, there isn't a clear product that we can use that as easily protects the salivary gland, but some of the strategies that can be used, number one, is good hydration. Because as Kim pointed out, that's the main way that the radiation will be cleared from the body, and so that includes the salivary glands and everywhere else. So keeping yourself very well hydrated is very useful. He also mentioned the use of sour candies, and that's another thing that can stimulate the salivary glands and therefore can potentially reduce the amount of radiation exposure and damage to the salivary glands. And then some people also use certain types of mouthwash or ice packs on the salivary glands to kind of help with the inflammation and so forth. So there are a number of strategies, but nothing as clear as there is for the thyroid and for the kidneys.
Understood. All right. Thank you, Dr. Mitra. This, has been exceptional and very helpful. And it's been an honor for me to be here with you both, Kim and Dr. Mitra. So I'm going to go ahead and hand it over to Kim.
All right. Thank you. That was excellent. I like some of those questions. They answered some of my questions, or some of those questions answered my questions too. In the chat function, I'm going to tell everybody, you'll see a link to a short survey. Please take this survey to provide your feedback about this webinar. And I want to thank everybody, thank Dr. Mitra for his dedication and patient in our patient community. He really, for being such a rock star as he is, he really goes out of his way in this field. This webinar will be available in a few days on YouTube and on the website. If this information has been useful to you, we encourage you to donate to pheochromocytoma.org/donate. We have another webinar coming up on November 9th about navigating insurance and financial issues. Thank you, everyone who attended today, and goodbye.